I need to confess that I was one of those who parked some little way away, actually, because there wasn't any available car parking nearby, so I've had the scenic route into Princess Alice this afternoon. Welcome to everyone, and thank you very much for attending. My name's Simon Williams. I'm a GP in the Surrey Downs area. I'm also, for a title, the Clinical Director for Urgent Care and Integration at Surrey Downs CCG, and I'm also the Clinical Lead for End of Life Care at Surrey Downs CCG. And this afternoon's sort of events really are a focus around carers. And I can't impress more upon those of you who are carers, perhaps in the audience, you know, what an important role you have to play in actually caring for individuals in the sort of last period of their lives, and really has how we as organisations, and there are many organisations, providers, commissioners represented here this afternoon, as to what role we can play to support you in caring for your loved ones in a way that actually we can bring about improvements to that, as I say, that last period of an individual's life. So what's extremely important is to get audience participation. We can all sort of just sit and listen, but actually I'm a great one for advocating a lot of noise, encouragement, perhaps not too much booing or shouting, but actually anything that you can possibly say, you know, it is a great you know, contribution to any of the events you know, which are taking place this afternoon. So without any further delay, I'd like to introduce Leslie Goodburn, who I'm going to let represent herself and explain exactly what she is and what she does. So, Leslie, thank you.
So, my name is Leslie Goodburn. I'm going to talk to you today about love, relationships, empathy and compassion, and something called Homeward Bound. So I want you to imagine it's 2014, it's spring, it's bright, it's sunny, and you're looking forward to the rest of the year. You're in a loving relationship with your husband, wife, boyfriend, girlfriend, whoever it may be. And you've got two significant birthdays coming up this year. You're both going to be 50. And as well as that, it's going to be your 10th wedding anniversary. So you've got everything to look forward to. Life's great. And to celebrate those events, you've just booked the trip of a lifetime to go to China, Hong Kong and Singapore. So life's good. And you've got everything to look forward to in the future. But then after one of you feeling unwell for a little while, going to and fro to the GPs and the out-of-hours doctors, one night after work, you go for an emergency appointment with the GP, you're sent to the A&E department, admitted overnight. The next day they do a CAT scan, and unfortunately you're diagnosed with pancreatic cancer. Pancreatic cancer that is quite late stage, that has spread, and at that point in time you're told you've got days, maybe weeks to live. And as you might imagine, at that point in time, your world turns very dark. And that's what happened to my husband, Seth. Seth and I were married 10 years before. We've been together for 16 years. Life was great. Seth didn't feel particularly unwell until 2 weeks before his diagnosis. And we were suddenly given the news that Seth was dying. So we felt like the world was our oyster. We had everything to live for, and then suddenly the world shrunk back and we started to have pretty quick discussions about home being really the important place for Seth, the place that he wanted to die. But the progression of the disease and the responsiveness of the system meant that Seth was quite quickly admitted to a hospital, and unfortunately 33 days after his diagnosis he died in an acute hospital despite wanting to die at home. And that was partly because the disease was so rampant, but partly because actually the focus was on the medical side of things, the clinical side of things, the symptom management, rather than the holistic care, the understanding of what somebody who is dying wants to achieve. Even though someone is dying, they still have goals and aspirations, they still have things they want to achieve. But actually the conversations that we had were all about the symptoms. They weren't about Seth and what Seth wanted. And when we did talk about that, the system didn't really listen and respond. So, you may have read a book called Being Mortal by Atul Gawande. I don't know whether you have or not. If you haven't, it's worth a read. If you have, you're probably really familiar with some of the things in there. But really, three things. If someone had asked us three things at the point Seth was diagnosed, the three things were: what makes life worthwhile, what scares you, and what would you trade to achieve what makes life worthwhile. If somebody somewhere in the system had asked us those questions, actively listened and responded with compassion, then maybe Seth wouldn't have died in an acute hospital. Maybe Seth would have died at home. So when Seth died, my world turned quite black. Didn't quite know what to do. It was 33 days from the point of diagnosis to the point that Seth died. He was here 1 minute and he was literally gone in the blink of an eye. So 6 months after Seth died, I got the records from the hospital and I sat down to kind of write down what happened during those 33 days, to kind of chronicle what was the kind of chronology of what happened. And as I did that, shut myself in a room for a week and cried an awful lot. I found myself writing letters to clinicians, to oncologists, to physiotherapists, to pharmacists, that explained what it felt like to be me or Seth on each of those days. Some of those letters were really very positive about when people did listen and respond to it, how they made us feel like we were valued and worthwhile. But quite a few of those letters were around kind of how the system overshadowed the person and the person-centred care. So 6 months after Seth died, wrote those letters and the chronology, went to the CCG and spoke to the director of quality, who was going to do lots of things to make sure that we could learn from that experience. Also spoke to the local hospital and director of nursing. We were going to do lots of things to do work with pre-reg nurses, do training courses. But 6 months after those two different meetings, which weren't together, my idea was that as commissioner, provider and carer, we would all sit down together and talk about what the learning was. 8 months afterwards, no one came back to me and nothing had changed. And at that point in time, again, it felt like the world was very black, because I'd kind of chronicled what had happened. I wanted to share it. I wanted to share it to improve, not to criticise. I wanted to try and make sure that our experience wasn't repeated by other people, but that didn't quite work. So in the meantime, through a partnership that initially started with the National Council for Palliative Care, which then merged with Hospice UK and became Hospice UK, we took the letters that I'd written and we decided to develop a play called Homeward Bound. It was a joint exercise between St Giles Hospice up in Staffordshire, NHS England, Hospice UK, Pancreatic Cancer UK, Leeds Teaching Hospital, myself and the playwright Brian Daniels. And we produced a play called Homeward Bound, and that was launched in March 2016. In March 2017, we actually developed a film of the play so that more people could see the film and more people could kind of learn from that film. So today, we're going to watch Homeward Bound first, and then kind of capture some thoughts about, from a systems perspective, perhaps what could have been done differently, and prompt some discussion. So, make this work so smoothly. So this is Homeward Bound, this is Seth's legacy.
I'd like to welcome you to Homeward
just wanted to open it up to any thoughts, anybody want to share anything as a result? It's okay, you don't have to.
Well, that's the second time I've watched that, and I have to say I'm equally moved the second time I've seen it. I mean, there's lessons there for everybody, I think, in whatever we do, to take out about stopping and thinking really about the impact of actions that we do on other people. It's such simple things that have been changed in that, because have made yours and Seth's journey more comfortable. I mean, the end was the end, you couldn't change that, but you could change on the route, and I hope certainly that I will take that away, and I hope that people in my organisation will reflect on that.
So, a little bit of feedback from people who've watched the play or the film. I've gone from thinking about difficult conversations to brave or courageous conversations. I think if Seth and I had different conversations, more honest and open conversations, and people have listened and responded, then things may well have been different for us. This one was from a medical student. I believe the play and subsequent discussion has been the single most useful teaching experience I've had this year, and will ultimately make me a better doctor. So up until now, Homeward Bound, the play, the film and the educational resource, because you can also download the educational resource, has mostly been used at kind of end-of-life conferences, improvement conferences, educational sessions at hospices and within hospitals. But talking to Debbie, we really wanted to use Homeward Bound in Surrey with the work that you've been doing around integration and all the carers work, to really think about not just kind of the small changes that people can make in practice, but also think about the system level changes, thinking about the head, the heart and the hands, and how all that may come together to kind of change the experiences of carers around end of life. So we were hoping that from the kind of session today that we could think about Homeward Bound in terms of the head, the heart and the hands, and the work that we've been doing, and think about through the sessions later today and going forward how that might kind of transform the system in terms of better end-of-life care. In the film it talked about the Pleurex catheter, which would have got Seth home and allowed the fluid to be drained from his abdomen at home. Nobody offered that. I asked for it. It took me 5 days of arguing about nice guidelines and high volume paracentesis, and eventually somebody listened and said yes, a Pleurex catheter was an option. They then came back and said community nurses weren't trained to administer a Pleurex catheter in the community. I asked them to train me, but by then Seth had deteriorated so much, and I was so worn out with arguing with a system who really weren't listening to me, weren't responding to me, that by the time we got to the point where we could get a Pleurex catheter and somebody could show me how to do it, I was so stressed out, Seth was so poorly, that I decided actually that my time was so short with Seth that I wanted to spend it with him, not learning how to administer a catheter. But actually, if that catheter had been there at the start of those 5 days of arguing, the training had been done, maybe Seth could have died at home. And quite often people say, watch the film, they say, well, that would never have happened because we've got loads of community nurses trained. But if the hospital isn't offering that as an option to get someone home, it doesn't matter how many community nurses you've got trained. In terms of the palliative care team, it took 14 days from the point of Seth's diagnosis for the first contact with any professional about the choices we might make. But we've been told Seth had got days, maybe weeks to live. So thinking about the system, thinking about the head, heart and the hands, how can we in Surrey Heart kind of bring that all together, building on the work that we've already done in terms of integration and using Homeward Bound as a kind of catalyst to have some of those discussions. And Homeward Bound is Seth's legacy. Thanks for listening.
Leslie, thank you very much for sharing, a very tender and I think very useful, teaching aid for all of us who work actually in our various provider groups as to what are the important aspects both for the individual and obviously for carers at a difficult stage. Can I just ask, just with hands, who has actually seen the Homeward sort of Bound play before, and who is using it as part of their? So the first question is, who's actually seen it, and then the second question I'd like hands is actually who is using it as part of their sort of teaching. So the first question, who's seen Homeward Bound? Very few, very few. And those who have seen it, have you incorporated that into your sort of teaching programme?
Yet, because only saw it last week, but I've immediately circulated it to my manager, and I hope he will be able to roll it out.
I have to say, it's the first time I've seen it, and it is very, very moving, and does actually address, I think, a lot of those issues and concerns that we find, I think, difficult in our programming and processing. As I can say that as a healthcare individual, that it is often important to reflect and try seeing this from the point of view of individuals and carers. So certainly I found it very useful, Leslie. Thank you very much for sharing that. I'd like to introduce now Caroline Hodgson. Caroline, I'd like to ask you to spend a minute telling who you are.
Sure.
And what it is that you actually are going to lecture us on this afternoon.
Okay. Hi, I'm Caroline Hodgson. I'm the social work lead for Woking and Zambia hospices. As you can see, I've got sort of two altogether. There's some of my colleagues from the other Surrey hospices will be joining the second bit, so we might sort of compress it a little bit with time as it is. So the first bit that I would like to talk to you about is how do we identify and assess carers' needs within the hospice. It's quite apt that this is this week, because this week is Hospice Care Week. So we're talking about what hospices do. If you go on social media, you can find lots of videos about how hospices support our community, and actually the awareness or lack of awareness that the public have about hospice care. So we know that the Care Act gives a national criteria for adult carers to have an assessment, and that's great. It's aimed to be a sort of holistic assessment, and there's no hierarchy of needs in the needs identified. And the idea being that wherever you go in the country, it's the same criteria, it's the same that the needs that's being assessed. But actually, if we're looking at in end-of-life care, does that really fit with what we're doing? Does it fit with the needs of the carers that we're supporting? Does it identify all of their needs? What then comes of that assessment? With austerity and changes in budgets, we know that the approaches across different local authorities can vary quite wildly as to how that can then be approached and put into practice. That's obviously the ideal versus what we know as the reality of it. One of the things that always kind of surprised me is that the Dimbleby Cancer Care report that came out last year, saying that on average, carers of an individual with diagnosis of cancer providing 70 hours per week of care in the last 3 months of life. And that can be something that can, as in Leslie's case, it can happen almost instantaneously and just step up to this unsustainable level. So across the hospices across Surrey, we've sort of looked at what we can do in our part in identifying carers' needs. There's several different tools that are out there. These are two of them. There's Zaret carer interview, and the carers alert thermometer. Both of them are evidence-based tools, and they are used in different areas. I think that personally, find the Zaret one, some questions can be a little bit more negative. Sort of, do you feel you've lost control of your life since your relative's illness, and some of those, sort of how it frames it for people. And I think the Carers Alert Thermometer has a great visual sort of thermometer of where people's needs are escalating, so it can look a bit busy. So the one that, another evidence-based tool, which you've got a copy, I have the inspection copy because I think I'd get in trouble if I showed one that didn't say that across it. So this was developed by two people at the University of Cambridge and University of Manchester. The Carer Support Needs Assessment Tool. So in Surrey, this is used by most of the hospices, so that the idea is any of our staff within the hospice can work with carers to look through these questions. And these questions they're designed for palliative care, for end-of-life care, to highlight some of those needs that might not otherwise have come up. And I think one of the things is that it's, as far as possible, having an organic conversation and letting that flow, but having that bit of structure that sort of pulls out a little bit more of that information. The idea of this is that it's led by the carer. They're saying, okay, so actually some of these areas that we might need support with, but they're identifying and they're picking what the priorities of these are. It's also quite a flexible tool. There isn't, so this is it, and then you decide as an organisation what comes after that. So within my hospice, we have an action plan that we've created that will work together with the carers, and that's about what their identified needs are and then how we're going to work together to address those. And working on sort of a couple of priorities at a time, because it can often be overwhelming when you get to a certain point. In other organisations, they've used it to look at carers across the organisation and identify where they need support groups, or there's a gap in their sort of organisational service. So it's a very sort of flexible tool. It's also, from a hospice point of view, it's good because it's free training and it's free to us to implement, but it's also got a very strong evidence base behind it. If you look up, it's Gunn Brandy and Gail Ewing. They've got various studies that they have published in relation to this tool. So it's a 5-stage approach, and it's also just sort of shows about the development and testing of the Carer Support Needs Assessment tool. So I think one of the things that I've seen with this and using this in practice has been that we can all fall into that trap where you go into a situation thinking you know what the answer is, and then you get there and actually it's something totally left of field. As an example, I was working with a lady who cared for a daughter who was younger and sort of profound disabilities. And actually the thing that came out for her was she was so worried about the future and her future when her daughter died, but she felt so guilty thinking about that point when her daughter had passed away and what her life was going to be like, but she was so worried about how things were going to change. And actually this allowed us to have a really open conversation about that. So within this tool, we can also use it to review, so we can sort of start with a couple of different priorities. We can then work with carers, we can show where there has been improvement for them, where there are other areas that have come up. And it can also facilitate an open conversation between the carer and the patient, or the carer and other family members. for example, there's been situations where spouses caring for their partner and other family aren't aware of sort of how much that's putting onto them. And actually this has allowed them to have an open conversation and go, do you know what, I didn't realise you weren't getting any sleep. How about we can set up a bit of a rota between us to help out, and there's other things that we can look to do. And I think that's one of the key aspects with this, is having that open conversation and those very difficult conversations about the future, about the complexities that can come with end-of-life care. So I did it. If you have enough time, I sort of included. There's you will get sent out a link to these. There's some case studies that were provided by the team who made up the Care Support Needs Assessment tool. There's about 5 case studies that go through sort of how the process, how it works, work in practice, and what the outcome and the benefit is. So you can have a read through those in your own time. So I've included this as just one of the examples of how the process can work and how it can be an addition or a sort of an augmentation to the sort of standard local authorities Care Act assessment process and what it adds for us in end-of-life care. So this was allowing the carer time to have a look through the questions and the areas in her own time, and to allow her to think of what she thought her needs are, and what actually the focus is for her. And then that leads on to having a conversation together and identifying what those needs are. As I said there, that actually the priorities that the carer identified were different to what the healthcare assistant thought they would be. And that actually her priorities were talking with her husband about his illness and understanding it more and having time for herself in the day. And that she wants to be able to spend time with her grandchildren. And then that's where, as a hospice team, we can then think about a shared action plan and what aspects we can help with, where there are gaps where we can look to work with other voluntary sector providers. So the benefits that were from this was that that they were able to build up a better relationship between carer and the healthcare assistant, and actually they were able to have more open questions and conversations. And for me, I also see it preventing those crisis situations where we're making assumptions about what somebody's needs are and where they are in a position, and they can continue on while their loved one is suffering from a terminal illness and they're providing 24 hours a day care. Actually, we can highlight those difficulties much earlier on and prevent it from ending up in a situation where we have limited options. So, would any of the other jobs for me?
I was going to suggest that, Caroline, thank you very much just for introducing the Care Support tool. I think the next, I'm just conscious of time, and I think the next discussion is really bringing in representatives from Phyllis Tutnell and the Princess Alice. Would it be an opportune moment maybe for those 2 individuals to come up and move on to the next part of the item, and then perhaps to leave questions that you could answer when you've discussed your carer and family sort of support services?
Yes,
Thank you.
Claire isn't able to join us today, but the other hospice representatives are welcome to join us if they like.
So, to stand up?
No? I'm good. You're just going to sort of flirt over there for the support. Okay. We decided that as a sort of hospices who work within Surrey, that we would do a joint presentation. We've looked at what we think the key themes are from Homeward Bound, and then we're going to sort of go through those and see how, as hospices, we address those needs. We're very lucky in Surrey. We have these 5 hospices that cover the whole of the county. Shooting off place, it's Children's Hospice, and then the 4 adult hospices. That's a lot of the areas in the country don't have that many at all. So these are different care representatives from the different hospices, and Rosie and I are representing them today. We're representing everybody, yes. So we're looking at how can we learn from initiatives such as Homeward Bound to improve carers' experiences, and then looking at how, as a multidisciplinary approach, we can look at this across the county and care and circumstances. How barriers some carers can face to be overcome, and the range of services that the different hospices provide.
Okay. So, shall I go through this one? So this we talked about the film that we've just seen. We looked at the fact that some of the challenges that we face, particularly by Leicester in this case, that such poor communication from some clinicians, and possibly a lack of palliative care knowledge from some clinicians who aren't in the hospice movement, and being shown a lack of dignity and respect, which I think came through on more than one occasion in the presentation that we saw. And we're not having appropriate space and ensuring their loved ones' death is as good as it can be. And I think I'm quite new to the hospice world. I'm 4 months into this. My background is in working with parents with disabled children. So for me, I was a nurse once upon a time, but that was a but to come into the Princess Iris Hospice and to come into this world, all these things, of course, the hospice movement are looking at every day, all the time. And the idea that there isn't an appropriate space for somebody who's very sad or very upset or who needs a little bit of time to themselves is hard to imagine. But of course, when you're in an acute hospital setting or another part of the world, it's not, we can't be taking it for granted. I think that's what I mean.
So communication in specialized palliative care. One of the things that we are lucky to have within the hospice movement is that we often have a higher staff to patient ratio, especially in the acute sector. This is what we do to support patients and their families every single day. So our staff have the knowledge, the skills and the time to communicate effectively with patients and their families. We have a high level of staff training in advanced communication, and it's staff above a certain level, that's just a standard practice that they have advanced communication training. We have a multidisciplinary team communication approach, and which looks at ensuring that the carers' needs are considered in that. I mean, within the hospice, we have occupational therapists, physiotherapists, counsellors, social workers, doctors, nurses, a wide range of professionals. To start with, who have the experience and expertise in end-of-life issues. And with the higher staff to patient ratio, that's part of that is the ability to provide that time and that additional sense of support to patients and their loved ones. There's additional support for carers, so therapeutic groups, individual counselling, therapies, education workshops, the assessment that we've just talked about. And we also have specialists in supporting children and adolescents, both before and after bereavement. And we've got good relationships with our local GPs, district nurses, and acute hospitals, so that we can share that best practice.
So we've also got the access to specialist palliative care knowledge, and carers are able to get access to advice and support from palliative care nurses and doctors giving a consistent approach. I think one of the things that I can remember from before is that if you've got somebody who's really poorly and really sick, as a clinician, your immediate instinct is going to be to that person, because that's what you're there for, to a certain extent. And when you turn around and say to the carer, and how are you? Sometimes the carer thinks, well, that's the first time anybody's asked me how I am for a long time. But it's something that is kind of standard practice when you've got. And then we're recognising the gaps in the knowledge around areas such as advanced care planning and providing support to carers. And that's something that if everybody was doing their advanced care planning really in advance, we might just stand a chance of being able to get it right for people, particularly if they're thrown, as Leslie and Seth were, into a complete whirlwind. Probably never thought about advanced care planning before that date. Why would you if you're planning a trip to the Great Wall of China? And then also we understand the importance of the care after the death and the bereavement support. That's all part of the hospice legacy as well.
So within all the hospices, we have private space. What you can say, all of our rooms are individual rooms, and most of the rooms in the hospices are individual rooms as well. It's standard practice that family members can stay. If family members would like to move in and sort of camp themselves out in the room, okay, then that's fine. We have chapels, we have family rooms, we have that space to have those private conversations, and space that for a carer to be nearby but take that time out, so they can go and have a complementary therapy session while still being in the hospice, completely open visiting hours. Looking at the different ways that we identify carers' needs and the individualised care that's looking at what is important to individual patients. I mean, you see it sort of every now and then in local papers and things like that. We have weddings or vow renewals, or we had a Shetland pony with a unicorn horn come on one occasion. Just sort of whatever it is that's is important to somebody and to that family. We facilitate family parties and all sorts of things just to provide that dignity and respect for families and carers. And the need for information and support on an ongoing basis, that our doctors and nurses, other professionals are available to be able to have that time and space. And I know when our doctors are clerking people in to the hospice, that sort of initial conversation can easily take a couple of hours because they're going through everything with the person and allowing that person the time to talk about what's going on for them, what the information is that they need, and having that space.
So yes, I think the appropriate space issue we spoke to just now, and there isn't a one-size-fits-all, so that some families and carers will require space on their own, literally to be completely on their own, and sometimes they'll all want to be together. And we need to know when to offer those options. And obviously we need welcoming spaces for families and carers, make sure that there are spaces for people who've got children. Sometimes people bring in their animals as well. You know, we've just got to make sure that we can welcome whoever is required to come. And also, at the same time, let's not be here the whole time. Let's respect the need for intimacy. There may be a time when actually people just want to be left on their own as well. And that's also okay. And understanding that the carers may wish to be close by so that they can stay if they want to. But equally encouraging them to look after their own well-being. And that sometimes if they need to get out, they need to get out too. And allowing them to have that space without feeling guilty and make sure that that's available to them.
And one of the things that we talk about a lot in hospice care is a good death and what a good death means to different people. So again, the specialist skills from our staff to recognise and resolve palliative care symptoms. So if somebody is distressed and agitated, that how our staff can support somebody and family with that as well. Being honest, but but sensitive with carers about what's happening, and that time to talk to the doctors or the nurses, whoever it is, about what's happening for their relative or loved one. Respecting a patient's wishes, their preferred place of death, and work towards meeting these wishes. So one of the things that, to come into palliative care, that I've noticed is this: there are times that we have to react so instantaneously that somebody wants to get home and they want to get home, so we have to do it right now, and it's got to be because you have a very short window to be able to do that and to meet that person's wishes. But also, if they need the support of the hospice care, the inpatient ward, and being able to stay there as well. I'm a process after death that treats patients with dignity, allowing carers time with their loved one when they die, and the different hospices have sort of slightly different approaches to that, but it is all about supporting a loved one however they might need. It might be meeting religious or cultural needs. And then bereavement support. So we have counselling, bereavement groups, and this ongoing support is it's not sort of time limited 6 sessions and you're gone. You know, we have people who call up sort of a year, 2 years later and say, do you know what, actually I really need to look at and talk to somebody about this, and that's okay. So just a quick whiz through about the different hospices and what some of the things that we do offer. So these are some of the leaflets from Phyllis Tuckwell with their carer support groups, workshops that they run on teaching people about carers relaxation, and their hospice at home support. So Princess Alice.
So yes, but I won't go on too much about them because you'll be able to see it all around the hospice. But we have a lot of offers for carers, including a lot of the things we talked about: the carers days, the PAPA days, the therapeutic sessions, helping with their bereavement, and we're about to hopefully launch a carers education course for those people who can make that in January, which will be a course of 6 sessions. But I can talk about that to you in the break if anybody would like to speak to us about that.
I don't know very well, did it? And then different sort of services that we have working in Zambia, 2 hospices, and as well as that, all the hospices have hospice at home services to provide specialised care in people's own homes. And then St Catherine's has caring confidence, another sort of workshop type approach.
Excuse me, it's a slide. It's not actually a workshop, it's a new project.
Oh, they're a new project.
So we've got a new project where we're going to be working with, like, looking at people at the end of life, family and friends. So we've won someone for a bid. So what we're doing is we're going to go out and see what actually informal carers need to support to look after people at the end of life at home. I'm running up to death, so it's going to be a really practical based workshop, and it's going to be like an MDT approach and coming a little bit away from the medical model and make it a bit more of a social model.
There we go. Thank you for correcting me. And then Shooting Star Chase, the Children's Hospice, with their family support, respite that offer in the hospice, hospice at home respite services, and the support, pre-employed bereavement and post-acute for children and families. And some bereavement support that is offered, as mentioned, across the hospices. There's counselling, there's support groups, befriending services, follow-up visits from clinical nurse specialists or doctors or social workers to talk about what's happened and to allow the carer or loved one to kind of go through what occurred and what that was like for them. And we also continue to offer yearly remembrance services so that if people would like to, that they can maintain that link with the hospice. Let's start with some of their leaflets for different bereavement support they offer. And then this is, again, this is the Shooting Star Chase, so similar to the bereavement support that they're able to offer.
I think one of the big differences for us as a children's hospice is that we can keep the young person who's died with us. I think the volume of the deaths you can have in an adult hospice means that they have to move on to the mortuary, whereas we keep the young person, or we have cold mats at home where the child can stay until the funeral. So there's a very different approach around the after death of supporting the family. And of course the whole family, we have suites of rooms for each family to stay in. So the family can stay there, do their own cooking, and essentially live with us until the funeral happens.
So it sort of gives you a flavour of the hospice which we've got in Surrey, and actually the sort of full service approach that we offer to patients, carers, family members, and that's both supporting patients and then the bereavement support for carers and families. So thank you.
Thank you very much, Rosie. Caroline, can I just, will you be around in the break, the tea break?
Yes.
And staying afterwards? So it would be perhaps a good opportunity to offer your input or answer any questions, please, during the current tea break. So what I'm going to suggest is we break now, if that's all right. Tea and nibbles, if there are any, biscuits. And then we assemble again perhaps in 15 minutes. Thank you. Okay, everyone, thank you very much. Now, just before I introduce Joe and glasses, Julie, I just want to hand these little cards out. Leslie has asked that if I could just distribute these. These are in response to the Homeward Bound video that you've seen. Essentially, just put your contact details on the front, and then on the back is actually what 3 things do you plan to do, having actually seen the Homeward Bound video. So I'm going to start at the front, but if we can pass these round, and please, if you would, complete those, and we'll collect them at the end, and hopefully, as I say, that will help feedback to us as to sort of improve all the aspects of care that we are able to offer to patients and carers and families. So, without further ado, I'm going to introduce Joe Thompson and Julie Doughty, who I'm going to ask to introduce themselves, if they wish. And I'm going to lead this, what is going to be an interactive session. All right, so a little bit of talk, lots of noise, because actually it is what you say and it's what you challenge back that really makes the difference. It's very easy just to sort of talk and lecture, but actually it's what you say on the ground which really makes a difference to sort of shape the type of service that we can sort of introduce. So, over to you.
Afternoon, everybody. I'm Jo. I'm the lead nurse for supporting and palliative care at the Royal Surrey Hospital. So I'm just going to spend the next few minutes talking about some of the ways we aim to support carers for patients who are at the end of life in the acute sector. So I'd like to talk about a few trust-wide initiatives that we've got, but then I'd also like to tell you a bit about the supportive and palliative care team. So, as much as we know there are many, many people who want to die at home, actually for some people, hospital is the right place to die, and it's where they want to die, and sometimes that's where they feel safe. They may have quite a lot of their care there, so for some people it is the right place to be. There have been a couple of research studies done, and one of these was done firstly in America, and then it was repeated here, and it asked 120 people what for them was a good death. So what were the most important things for them for a good death? And actually they said the top 2 priorities were to have their pain and symptoms controlled and not to be a burden on their families. So those are some of the things that we sort of try to think about when we're looking at people in the acute sector. So how do we support carers? Well, where possible, we try to look after patients who have been identified as being at the end of life in a single room. And we talked about the environment and things in the hospice. And being in a single room means that carers have open visiting. It means, again, they can stay the night, and we provide camp beds, and we provide comfort packs, toiletries, and things like that for carers to be able to stay the night. So it's really trying to unmedicalise the whole sort of environment for people. As you can imagine, in an acute hospital, single rooms have to be used for lots of different reasons, for people who have infections, for people who are prone to infections. So there's a big demand on single rooms. But we're really actually quite proud that the whole trust, it's a real culture, we really prioritise single rooms for people who are at the end of life. And I did an audit of the deaths that happened last April in the hospital, and actually 32 out of 37 patients were able to be cared for in a single room. One patient actually didn't want to be in a single room. So again, it's about asking people their preferences, they felt they wanted to be in a bay, where there was a bit more going on, things like that. So it's about that individual. We also have quiet rooms now, which are available outside many of the wards and on the floors. And again, talking about kind of sensitive conversations and delivering of difficult news. We've got a few rooms that have been newly decorated with kind of nicer furniture, so that we're not actually having these horrible corridor conversations. So that's one of the sort of environmental things that we really prioritise in a potentially sort of difficult environment sometimes. Some of the other things we have is we have something called a carer passport, and this is something that the nurse in charge can give to a carer of somebody who is being cared for at the end of life on the ward. Now the carer passport again allows completely open visiting, so carers can come whenever they want to see their loved one. They can also get very involved in the care if they would like to. So if they want to be involved in personal care, feeding, or something like that, they're able to do that. It also allows reduced meals in the canteen and it allows people to have free tea and coffee and things like that on the ward. So that's just a small way that we try to kind of support people who we know are at a very difficult time with their loved ones. The other thing we provide, and our team provide this, is a free car parking permit. So we know that car parking can be a massive bugbear for people generally at the hospital. So when people have been identified as being in the last week or 2 weeks of life, our team can provide a free car parking permit. And I think this is a huge thing for a lot of people, not just because of the cost, but I think it's that whole not having to keep going and renewing tickets and things like that. It's really important. The other thing we've written is a leaflet called What to Expect in the Last Days and Hours of Life. This is something that we've put together and explains to people how they might see their loved one deteriorating, changes they might see. And something that's very interesting with this leaflet is we have a stash of them outside our office along with a number of other leaflets. This is the leaflet that is always empty. People pick up this leaflet a lot, and I think sometimes this is the information that people do want to know. They may be a bit frightened to ask it, a bit frightened to say, look, what am I likely to expect? But we are always topping up this leaflet. And that's just anecdotal, but that's just something that we've seen. The other support we have is we have a spiritual care service, and this is for patients and carers. And it's really important. We've got a new chaplain who's joined the trust, and he's very, very keen that it is not just a religious service. So we really promote this as a spiritual care service. So the chaplains or the people that work with them can come round and talk to and support carers, spend time with them. They can go to the chapel, or they've got another room that's next to the chapel that again is non-religious, just to give carers time. We have a volunteer who's joined our team, who is covering one afternoon a week at the moment. She is an amazing lady. She did used to work with crews. And she's somebody, when we highlight maybe people who, they might want to speak to somebody, but also she sometimes goes and sits with patients while the carer maybe goes to M&S, to go to eat or go for a drink, but they know that there's somebody sitting with their loved one. And we also have the Fountain Centre, which is an amazing charity in the hospital. It is for patients with cancer, but they offer varying different levels of family support. They offer counselling, they offer a listening service, they come up to the wards and they support carers. The other thing they do is family support and counselling, so we've got some fantastic children's counsellors who come and work a lot with the young people. And they also hold, every month, they hold a bereavement service and a bereavement group where children and their families can come and work through some of the issues following bereavement. We have an end-of-life care strategy group within the trust, and this is a group that meets 4 to 6 monthly. It's not just the palliative care team on that group, we've got various people, and we look at all of our end-of-life care issues. We look if we've had any complaints, we look if we've had any compliments, and we just look at the way that we're doing things. We have a lay member on that group. She's a lady whose husband died in the trust a couple of years ago. She sits on our group, she reads through things that we've written and just gives us her perspective, which is great. So the palliative care team, we're a team of doctors and clinical nurse specialists with experience and training in palliative and end-of-life care. We're a 9 to 5 service 7 days a week, so that's really important. Try to recognise things don't just happen in the week. And our consultants are on call out of hours as well, 24 hours a day. We accept referrals from any healthcare professional, and we encourage community palliative care teams to inform us when their patients are admitted from the community, so we can try and get to see them quickly, try to turn them around to get them home if they want to, or provide that support as soon as possible. So our team, we see every single patient who is identified as being the last week or 2 weeks of life, and we review them every single day, and that's 7 days a week. Now, not all hospital trusts do this. Some hospital trusts use an end-of-life care plan that guide other staff. What we have found is that actually it's an excellent way of teaching other staff caring for people who are at the end of life. So we see each of those patients every day, and we aim, our goal is to touch base with a carer or the next of kin of that patient every single day as well, be that face-to-face or on the telephone. Had a gentleman who was dying on the medical wards a few months ago. His next of kin was his sister who lived in Wales. She couldn't get to him. We spoke to her every day to give an update. She really appreciated that. We also liaise with relevant community teams, and we can refer to hospices, or we can help, if possible, and if the care is available, to get people home if this is the wish of the patient. So I was asked also to look at what gaps we felt we had in the service of the Royal Surrey for for people who are at the end of life. And actually one of the things we've struggled with quite a lot is providing an appropriate bereavement service. So we have sort of the Fountain Centre provide excellent bereavement service, but it doesn't unfortunately cover the whole sort of broad spectrum of people that we care for. So we set up a pilot service a little while ago along with Crews, where we offered every relative who came to pick up a death certificate, we offered them an invitation to have an appointment with Crews or an appointment with the spiritual care service. We had really limited uptake. I think we just had one person who made an appointment. And we kind of identified maybe that wasn't the right way to offer that service. So again, we're working with Crews a bit closer, and they've just come up with a really nice leaflet for us that we're going to try and give to people when we give out our bereavement booklets and things like that when people die on the ward, to see if that's just a different sort of way of offering this service. So that's what we do at House.
Thank you for inviting me. My name is Julie Jackson. I'm the community hub manager working for CSH in the community. I also manage the community hospice and nursing service. I've been nursing for many, many years. I've worked in intensive care and I've been a community matron. So it's good to talk about. I suppose I'm lucky in a way that I'm talking about end of life at home, because that's where people like to be. I've been asked to sort of talk about the barriers of end of life at home, and I will do that, but I just wanted to open it out a little bit to say who the sort of people you might meet. So community matrons, specialist nurses, district nurses, everybody knows district nurses, and end of life carers are very much so. And we tend to look at the last year of life, the last 2 to 3 months of life, and the last 2 to 3 days of life. They're quite different, and they need some preparation. And I think looking at home ground it's key to look at timeliness and where we're going with it, and also to look at the different diseases or cases that we look at. So dementia is definitely has a trajectory. People, carers are living at home with people with dementia, Parkinson's disease, motor neuron, COPD. I've got HR, that's a typo, that's half a year. MS and frailty I've put in there because I think district nurses, community matrons tend to look after people with frailty, and they are moving to a journey on end. So it's lots of different things, and as we saw, pancreatic cancer. So I haven't included cancer because I know that we're talking about it today. I just wanted to open it out to lots of different disease cases. So thinking about the barriers and thinking about how we in district nursing or the community support people at end of life. Obviously I put at home capital letters, and I think that's where most people would like to be. But things we need to think about, things that we come across, are the physical changes. So it may be more short of breath, it may be less mobile. How are you going to deal with that at home? It's quite different. So we've talked about the hospital, we've talked about the hospice, but at home you've got your furniture, you've got your pets, you've got lots of things going on. That's where you want to be, of course. But how do we help that person living at home at end of life? And I put emotional changes because I think that's both for the person themselves. Obviously, Seth was really eloquent about how he felt. He was angry, and then how was he going to cope, and then he was worried about Leslie, and it's all those emotional things. But for Leslie as well, I imagine there's huge emotional things going on. Sadness, you don't want to share that with the person, you're frightened. So it's all those things that we need to consider when we're looking after people at home, because it's almost like you're in the real world at home, isn't it? You're not in an environment where people are looking after you all the time. Environmental changes, so the barriers about where is the bed upstairs, can I get upstairs, can I move back downstairs, what sort of things do I need, do I need equipment to help me, and all those different things. I put activities of daily living because I really like that. That is an old nursing term. But when you think about it, it's about how am I going to get to the toilet? Because I know for sure if I'm not well, it's the first thing I want to know is how I'm going to get to the toilet.
How am I going to be dignified in living at home, living with my partner, living with children? So it's all about those activities of daily living, and I think that's what community nurses specifically look at when they're helping the clients plan their care. So I've put responsiveness because I think, when do we start? So we've already looked at different trajectories, whether it's the last year of life, or the last 2 to 3 months, or the last 2 to 3 days. How responsive can we be? So we talked about hospital and getting people out of hospital. But of course, it would be lovely if you could just come out of hospital and go home and have everything in place. But it doesn't always work that way. As much as we'd like it to happen, we need good communication. So thinking about things, as Jo mentioned, what gaps are there? And we do have some communication issues, but we're not always responsive in time to getting things ready. Then we have to call the equipment provider, get that in the house. There's all these things to be ready for. And we can do it. It's just we have to think carefully about where we're going and the timeliness. Who to contact. So again, if you're at home, you've got the whole night to be with your partner who's not feeling so well, or maybe on medicamental medication. Who am I going to contact? So we at CSHI, we have a contract with the night response team here at Princess Alice. So there's always somebody to call. We have a twilight nursing team that you can call, and obviously so it's 24/7 that you can call. And we would expect our numbers to be in the house, because we would have already done an interview with the person, perhaps sort of nearing a year to the end of life, 2 to 3 months of life. You would have seen somebody to talk to, so you've got his contact number. And having those really important conversations, so what's it going to look like? What are we going to do? How is the person going to be? Are they going to be eating and drinking? All of those questions that we really need to have a thought by, so we can provide those conversations. Our district nurses, as I said, do end of life care. We probably have 4 people every week on our books who are in the last 2 to 3 days of life with some insurance and medication. So we would have already had those conversations. I think somebody mentioned advanced care planning as well. So it's difficult, but it's something that we need to talk about. Expectations. What are your expectations when somebody arrives home? How quickly can somebody get to you? So I think having all that information at your fingertips allows you to make decisions. So try to overcome the barriers if you're at home. So discussion with appropriate experts, whether it's your GP, your specialist nurse, your friends and family, is they're going to help you. Are they prepared? A good solicitor, yourself, the person you're caring for, because all those people have an important part to play in where you want to go. Time, so time is, what's the time frame? I don't know. My father passed away in 2011. He passed away in hospital and he deteriorated really quickly. We had 2 weeks. We knew he had bladder cancer. He was being treated for a year, but it was the last 2 weeks that he deteriorated and we went into hospital. But it's the time frame that you're thinking about, and I hope perhaps the previous slide has given you an idea about when you're having the conversations, taking you through the journey. And I've put knowledge, being prepared, question, can you ever be prepared for it? I doubt it. I don't think I felt prepared for it when my father passed away. But actually what happened was I was with my sister and my mother, and I actually knew what was going on. And it's having that knowledge, so I'm lucky because I've obviously been there for a long time. But when the doctor came in to us and said, oh, we need to have this conversation with you, my sister and my mother were thinking, oh my goodness, what's going on, But I sort of knew where we were, and you talked about that phone call during the night. So I've worked in intensive care, I've made those phone calls during the night. Something's happened, don't rush into hospital. You know, so I think perhaps having a bit of knowledge about what's going to happen is a good thing. Equipment environment preparation. So again, at home, what we do find is that you need a a bed that can sit up and do this and the other, but actually you've got a great big double bed in the room, you might need to move it. We've got to have that conversation. Is there anything we can do to help you with your furniture? Or do you want it to be like that? So it's having about these conversations. We've already heard about the caring packages that are in place. Do you want to do that? I suppose it's having a think, isn't it? I come across a lot of families who think, yes, I'm going to do everything, it's all going to be great, but of course, 4 weeks in, and it's really quite tiring and difficult, and it's about thinking about what I need, and then suddenly you say, oh yes, I want that package of care, and then you find that, yeah, there's a 2 to 3 week delay because you haven't thought about it, or there's not people coming in to help you. And then coming out from hospital to home or hospice. So again, I think from the video, I think probably we could perhaps, from the community, could we go into the hospital? It might be something that we could think of in the future and have that conversation to help expedite that person to come out. Because we do find very often on a Friday afternoon when somebody's decided, oh my goodness, we want to come out, it's quite difficult for us to do. We do our very best and we've got all the medications to pick up and we can do it, but it's much calmer and better if we have time to be. And then medication, palliation, and having the right medication at the right time. So again, it's all about thinking, district nurses will do this all the time. We have what we call anticipatory medication. So usually it's ready there when the person needs it. And then we obviously do our assessment to make sure we're going to the right drugs at the right time. Just to finish, I just had some thoughts and thinking about achieving dignity and comfort. Maybe it's something you might want to discuss with me or amongst yourselves. How do we achieve dignity and comfort? Because I think that's the driver for all of us who have experienced our partners who come to the end of life. That's what we want. So at home it might be slightly more easy. Expectations for yourself, and I could do on to others. But expectations for yourself. What can you really? You're in this situation that's very alien to you. And imagine if it's your first partner who's on the end of the life journey. How are you going to cope with it? So again, from the community support, we do provide that support. We're not there all the time. District nurses definitely are moving on, unfortunately. It's a bit like you mentioned the hospital bed, where the next person's going into that bed, and district nurses have to move on to the next patient and the next patient. So, but we do give you information on how to follow up, where to go. That's what we do, and then we allow our other colleagues to take their time. And then do unto others. So how would you want to? So I was watching the video, listening to everything that Seth has said, and you were thinking to yourself, well, probably yes, I would feel like that. If you'd suddenly come across this diagnosis and you'd be very cross and you would want to do this or that. So I think it's how I come across lots of people in the community, lots of partners who think that's what I want for my partner. But they haven't actually asked the partner, what do you want to do? Because actually the partner's thinking, I don't want you to go front, and nobody has spoken together in some situations. So I think as Simon said, it's all about making noise and any questions. And thank you for listening.
We will not let you sit down. You can fill the questions. Joe, please, if you'd like to come up, and the floor is the floor. So please, if you would ask any questions or explanation, please probe.
When you identify gaps in services, how do you translate them up to the CCG and commissioners? Because whilst we have 5 hospices in Surrey, we are so oversubscribed, and we serve a very small minority of people who are suffering with the prospect of losing someone they love without the support. And the support that hospices and end-of-life care services do provide are recognised here on the whole very good services. CCGs?
I think probably for both of us, we have strategy and steering groups that we meet regularly. And I know Susan Santos comes to our meeting.
Yeah.
And they look at the so we're very interested, I guess, not children, so that's children and families, but we're looking at the transition age group into adulthood. So we definitely talk about the gaps and then take
But there's a
them back.
difference, isn't there, about talking to them, but having that conversation with the commissioners. Commissioners seem to be, and I don't know if there are any commissioners in the group, but they're quite an elusive group of people sometimes. I'm trying to find who they are. And I've been working in this business for many years. But because of all the changes, finding who the person is that's the budget holder and can affect the change and allowing us to work together. There's a real will to work together, but I'm not seeing a real change happening.
Interesting. I don't know, Simon,
I hope that wasn't coming towards the. Christine, you're quite right. I mean, obviously, I'm clinical lead within a commissioning group, and I know we have our end of life, project group where a lot of these issues and challenges are raised, and I think it is a reality that we all recognise as individuals, within healthcare provision, that there is a finite sum of money, and we actually have to make the case. And I think, this is an area, it's an area that I feel very strongly and passionately about, and I'm very conscious at the moment that there are huge gaps within commissioning with regards to managing end-of-life care, at a commissioning level. And I know that's something that we're taking up at a very high level within Surrey Heartlands as an STP. But I think it is important that one has to, I think the trick is obviously trying to show ways by creating a pathway and improving a service, we're able to show, as a clinician, first and foremost, improvements to the outcomes for our individuals, and as this workshop is about, really for carers and their families. And then how that improvement in quality and outcome translates itself into sort of financial savings. That unfortunately, I think, Christine, is the reality of budgeting. You actually have to show that something will improve, flows and budgets, but the evidence is there. If we do focus on quality outcomes, then then it is quite clear that we can actually make a difference to cost savings, which we can invest appropriately.
And not all of them are monetary driven.
No.
Leslie made a lovely comment which I'd like to take away. We talk often in our profession about difficult conversations. We do lots of training. Leslie said courageous conversations, and I think brave conversations. And that's a different stance, a different approach. It gives a different message, and that's nothing about money.
No. And I think maybe it's very important is one of my other roles is integration. And I mean, listening just to all the conversations and discussions that have been taking place this afternoon, is what's really key here is the conversations that we need to start having together and working as a team. I think the challenge that we have is that historically we've grown up, with the advent of 1948, the NHS Charter and everything else. We've all popped up in little places, and it's time we actually got a full understanding of each of our various skill sets and abilities, and how we actually come together to work as one functioning unit.
I'm a lay member of Surrey Heartlands and the Greenlees Clinical Commissioning Group. So, Simon, I think you've done a really good answer. It was a bit you said about commissioners being elusive. I think that's the last thing we would want, and try very hard to make sure carers and families and patients' voices resonate at the heart of things. So get through to someone and say it good way, if that's the area that you are in, you are in. through the website, ring up. We would want to hear your voice, and if you had difficulty, talk to me at the end, because I'd want to know, particularly I have a late portfolio for supporting carers across the patch, and we don't want to be elusive. The last thing we want, and I'd like to talk to you really and make that happen.
Jo, I thought it was interesting that your team, the name has changed to supportive and palliative care. Is that changed sort of who you're able to support?
Yeah, I mean, we've always sort of wanted to see people sort of based on need rather than just diagnosis. The other thing we want to do is we're seeing a lot of patients now, we are seeing a lot of cancer patients who are got treatment-related side effects, so we're looking after them as well. And we really want to move away from the fact that it's just sort of, end-of-life care, but it's very much based on need. And that's what we ask when we get referrals in. We say, well, what can we add? What do you need from us, rather than this patient's got this diagnosis that needs to see this.
Thank you. That's all the time we have for questions now, but I think Jo and Julie will be sitting at the front for the panel discussion. So if you have any further questions that you would like to ask later, obviously please take them from them. So thank you, Jo. Thank you. And I believe this group now needs to go next door. I think it's next door. Oh. You stay here. Don't move. I'm strongly green. Excuse me. Quite right. That's a much better idea.
You could do a check something.
I think it was
I just need to get back
Okay, without further ado, we'll introduce Jenny. Please introduce who you are, Jenny, and please.
Okay, hello, can everyone hear me? Ooh, good, smashing.
My name's Jenny Pringle and I'm the Head of Care Operations for Crossroads Care Surrey. Has everyone heard of Crossroads? Brilliant, brilliant. Crossroads Care has been offering support to carers living in Surrey for over 36 years and have a wealth of experience dealing with carers' issues. Now, Crossroads Care Services started in Rugby in 1973 and is named after the soap opera Crossroads, shown on ATV, where they funded the support of the carer of a young man with disabilities who trained the character Sandy how to use a wheelchair, which is how we got the name Crossroads, which sounds an awful lot more like road safety, doesn't it, than care. Surrey originally had 9 branches, and in 2009 they merged into one charity named Crossroads Care Surrey. And one of our earlier branches, Crossroads Care Woking, started the end of life service by being awarded a start-up grant by Macmillan. And this funding has been continued by the NHS and now the CCG since 2011 through their tendering process. Now, you probably are aware, being all in the industry, but there are over 115,000 unpaid carers in Surrey. Every day, 6,000 people will start caring for someone close to them, saving the economy about 119 billion a year. And 3 in 5 people will become an unpaid carer in their lifetime. And I'm sure it's affected a lot of us here. Last year, Crossroads Care Surrey delivered nearly 15,500 hours of respite and support to end-of-life families in about 4,300 sessions. And we received 115 referrals from yourselves and self-referrals across. And the aims of our end-of-life service is to give people a choice of where they wish to die. For some people it is hospitals, for some it's hospices, but we know more and more people would like to die at home, and we're there to support them as part of the team with you medical professionals. One of the great things about our end-of-life service is that we can provide people with continuity of care. We can support carers and the people they care for initially maybe in our adult services, in our adult social clubs, out and about in the community or in the family home. And then when the prognosis is identified as less than a year, we can transfer them to our end-of-life service with usually no change to the carer support worker they've come to know. This year, in response to our annual survey, we've started our assisted holiday breaks, where we accompany you on a sadly UK holiday, so we're not jetting off to the Med, to provide care and support while you're away and help build those memories. As you can see from the results here, I won't go reading them, carers trust us. They trust us to send a well-trained member of staff who will arrive on time to give them a substantial break, on average 3.5 hours a week, that helps them keep going, have peace of mind and stay in better health. So how do you refer to us? It's jumped down, hasn't it? Well, it's quite simple. Anyone can refer, GPs, other health professionals, social care teams, voluntary bodies and the carers and the cared for themselves. We'll make contact with all our end-of-life referrals within 48 hours and arrange a time that suits them to go and do a personalised assessment. A carer support worker will then be matched to the family, and as their regular support, and if required, we build a team of care around that care worker. I'd just like to end by reading this lovely card that, would you believe, came to us just today. And to let you know, Penny is one of our care coordinators in the East team. Dear Penny, I'm so grateful to you for the Crossroads team you put together for C and me. They were all brilliant in their different ways, and each one became an important part of our family. There is no way I could have managed to look after C at home without their care, advice and support. I really think he couldn't have had a better death, and that was done in large part to Crossroads. To have enabled me to give both of my lovely men as good a last part of life, right up to death, is pretty amazing. I shall think gratefully of Crossroads for the rest of my life. You're a very special organisation. With many thanks, S. And I was so stunned by that, and it just says it all. It says about the passion that we at Crossroads have for the service that we give, particularly our end-of-life service. Any questions? No? We'll do that at the end.
We will bring some questions up, I'm quite certain that. All right? Give
Thank
people a chance to think of something challenging.
Lovely.
Right? Dr. Mary Davis, and would you introduce yourself again? Thank you.
My name is Mary Davis and I'm Chair for South West Surrey Cruise Bereavement Care. Have any of you not heard of Cruise? It's okay to say no because there were several in the other group who hadn't heard of Cruise, but you all heard of Cruise and what did you? That's great. Okay, so I'll tell you a little bit about Cruise. So it's a national organisation. We provide support for anybody that's been bereaved, and one of the things I think that's different for us from several of the organisations who've been talking today is that often the bereaved people who come to us many years after their bereavement, and we have no time limit on that. So that's something which we hope we can build into the services that you are offering. And we provide support for people of any age, and we do provide support for children. So our aim is for our volunteers to enable people to live with their bereavement, to live with their grief. And we have found that from our feedback and our evaluations that our clients do usually feel that both their emotional, mental and physical well-being has been improved. Our volunteers aren't trained as psychotherapists. They have specialised training in bereavement support, and I'll tell you a little bit more about their training. Cruise is a national organisation with procedures and protocols. We have 3 local areas running in Surrey: South West, North Surrey and East Surrey, and I'm speaking on behalf of them all really. Our bereavement volunteers undergo a training programme. Now, they're all volunteers, so most of them are doing full-time jobs, part-time jobs. They undergo a 5-day training programme for their training. We have a strict interviewing process before the training. We have an interview process after the training for them to find out whether being a volunteer for Cruise is the right thing for them at that particular time. Once they are up and working, they have regular training sessions once every 6 weeks, and they also attend regular supervision in the same way that any professional counsellors and other people would do. Some of the feedback, I won't read it all out, I'll give you a minute to read it. I think one of the things that we do is that the people that come to us often have abnormal bereavements or abnormal grief. But the fact that they come to us sometime afterwards means that it is often a complicated grief for whatever reason. So half our clients come from their GPs. An increasing number are forwarded from mental health services. Do any people here work for mental health services? Yes. 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 Somebody mentions they've been bereaved. Word of mouth and other organisations. Our clients do have to refer themselves. We don't accept second-party referrals, so they do have to ring us themselves, unless, of course, it's a child or they can't speak to us, because we find that quite often it's people say, I think you ought to go and get some help, and actually those aren't the sort of people that we feel that we can provide much help for. So initially the client rings in, they have a fairly lengthy phone consultation with a conversation with one of our trained volunteers. We now offer all our clients the opportunity to come to a welcome morning, which we hold about once a month, and they come to that. And at the welcome morning, we give them a presentation on normal grief, and we find a number of them say, that's fine, thank you very much, I don't think I need anything else, because we've normalised for them, you know, they might be on their own and isolated. But a lot of them choose to come to a programme of group sessions. We run group sessions and we have one-to-one sessions. And the interesting thing that we found is that as a result of the welcome mornings, many more people are choosing to come to groups because they come to the welcome morning, they chat to the other people who've been bereaved, they have coffee and all of that, and then they think, actually, I'd quite like to work with these other people as well, not just with one-to-one with one of the volunteers. So our groups are getting busier and busier, and the one-to-one amount of one-to-one we're doing is getting less and less, but we still offer both to everybody. Oh, sorry, they've missed half my slides, so I have to speak from my thing. Thank you. One of the things, right, sorry about this. We were talking in the other group about how we fit in with the services that are being offered to carers here, and we're very aware of the high standard that's being offered to carers within the systems that I've been hearing about here today. But I think we certainly don't see ourselves in competition, and I would hate that to sort of feel that it was we're better. I think it's very much horses for courses, and what suits the client is right for that client. And Fenella, who's one of our volunteers who's here with me today, we were just jotting down why some of the carers who've been through systems like this end up with crews. And the reasons we came up with one was delayed grief, in that they feel that they're perfectly okay, and it might be quite a bit later on. Not wanting to revisit the organisation they were with before. You know, the building has memories for them, and for some people it helps them, but for others it's a no-no. Sometimes it's a further bereavement. I mean, it can be the dog or something happens, and that brings them back into the bereavement and the grief that they were having before. And sometimes it's because their previous support network, I mean, staff change, don't they? And they may have had somebody here they were particularly attached to, if you like, and now it's somebody different, so they choose not to come back. So those are the ways that we feel that the people that you're all seeing might well come to us, and we're delighted to offer them that service at a later date. Just to fill you in with one or two statistics, this is Southwest Surrey and North Surrey, but not East Surrey at the moment. In the last year, we've seen 659 clients, of which half were referred from GPs. The number of volunteer hours is 15,500. So I think it's, you know, worth realising what they do. And we do offer now groups, one-to-one children, and we offer email and telephone consultations as well now. And because we're a voluntary organisation, we have financial constraints on us. It costs us about £200 per client, which is the money that we have to raise each year, which we do with local grants, local fundraising, and we have recently started asking for clients donations if they're able to give them. And in fact, that's been some of our clients have been very generous. We don't ask for a fixed price. We gather that Mind asks for a fixed price, and there's been a lot of conversation. But anyway, we make it as a voluntary thing, and people can either give or not, and that's done discreetly. So, anything anybody wants to ask me at this stage, or I'll come back to it later.
Mary, thank you very much. So there will be questions, I have no doubt, at the end. Lastly, Jane Finn. Not last, Jane, right?
I am last,
well,
but not least.
Not least, that's
and
right.
thank you for being here still. It's getting late, I know. I'll get on with it. I'm hoping next door this skipped and just rolled on without me really, so I'm hoping it won't do it this time. I'm Jane Bellingham. I manage the Brigitte Trust, which is a small charity based in Dorking, but our service covers the whole of Surrey. And I'll tell you what that is. We were started over 30 years ago now by a lady called Brigitte Watkin, and she started this service because she watched a number of friends die in acute hospitals, and because she wasn't a relative, she was unable to be at their bedside as they were dying. Remember, this is over 30 years ago. And she thought this was terrible. She couldn't do what she wanted to do and be with them, and she and also a number of the friends didn't want to be in the hospital. They wanted to die at home. In those days, there weren't the services that are available today to enable somebody to do that. So she said, I need to start something which will enable people to have choices, really, about where they want to die and how they can be supported, and the fact that friends would be able to do that. So she launched the Brigitte Trust. It's a free emotional service, up to 3 hours every week, provided by volunteers who are trained really well in listening skills. They're not counsellors again, who've heard this before, but they are very good at listening and supporting people when somebody has been diagnosed with a life-limiting illness. It enables them to be with someone at home where they are able to voice their fears and their concerns, and to enable them, whilst working with other agencies, to be able to, or better able to, more chance that they're able to stay in their own home if that's where they want to be to die. And that's why I think it's important. Today, what I'm taking away is better communication. We must talk to each other. I think the other thing is, it's not a competition. That was alluded to just now. You know, the one thing I noticed on the hospices slides was, I don't think there was a mention of voluntary organisations. We have a value. Use us. It costs money. We're free. Use us, and we can provide a really good service. But it is important that we talk to each other to enable that to happen, and to make sure that the client receives what they need. So we place the same volunteer in a home with a family when there is a diagnosis of a family member of a life-limiting illness, primarily providing that emotional support, but also some practical help as well. And that can vary from taking people to the hospital on appointments, to mowing the lawn, to making a sandwich at lunchtime, to taking them out to a place which was a favourite place of theirs that they're no longer able to travel to on their own, for example. And I'll share some more with you in a moment. As you can see, our strategy always is to keep that person, that family, at the heart of everything that we do. They are central, and everything else has to work around them. We want to listen to what the client needs. We refer to those people we support as clients, not patients, because we are not medically trained. We want to meet their needs. We want to have that flexibility. What works for me might not work for you. So it's important to, as Leslie said, you know, that individualisation, to know what somebody wants. And we only will learn that if we ask them. We do cover, at the moment, we're across the whole of Surrey. The emotional support I've talked about, it is that time to listen. With the best will in the world, if you're sat in an acute hospital corridor, trying to have a conversation, and you're a medic trying to provide another service, the chances that you can sit down for up to 3 hours and have a little chat is most unlikely. We have the time to do that. We don't pretend that we know all the answers, and we don't necessarily have to give the answers, but we do have to be there to listen, and that is what's important. Reducing isolation, that's really key, and seems to be a growing concern where you know, we have a good number of our clients are elderly, they live alone, family, if they have any, are living away, their friends, their peers have died, and they are really quite isolated. And when you're diagnosed with a life-limiting illness, of course that brings other implications. You can't get out to the club that you always went to once a week, perhaps. And the things that are on the wish list, you know, before I die, I want to make those memories, and acknowledging that we all feel differently. It's not a one fix for all. Family support at home, we aren't there just for the person who is ill, we are there for the family. So other members living in that household, we can sit and listen to a carer. I think that's extremely important, and Leslie highlighted that today. You know, who listens? I'm not sure what to expect. How will I cope? The children will miss their dad. I need time too. I need time to, as a carer, replenish my energy, my batteries. Time for me. I need perhaps a break to go out and see friends. And when our volunteers are with that person who is ill, the carer has up to 3 hours respite time. If they want to go out, they can do that. Go and have a sleep for a few hours. And sadly then, when somebody dies, we are there to provide bereavement support for up to 3 months at the moment. And then we can hand on to someone like Cruz, which is a wonderful connection. Practical help, I mentioned some of these. It can be anything. There are just some examples up there. So if somebody asks, we will decide whether or not with that volunteer that can be achieved. Obviously we have to think about the safety of the volunteer, but normally we can achieve that. Referrals can come from anybody. You pick up the phone, you don't need a GP, you don't need any other specialist. You can refer your family or friends, you can refer yourself. Once that referral comes to us, we will send somebody out to make an assessment. And that includes health and safety assessment for our volunteer to make sure it's safe for that volunteer to go into the home. I mentioned next door that just last week we had somebody who was referred to us who collected these, well, there was a grand assortment of knives, some of which is big, I'm not sure now, but they were hanging on the wall, and the man had a knife with him when the assessor went in, and she said, it was safe, it was okay, but she said, actually, I don't think we can risk placing a volunteer in there. I didn't feel comfortable. Okay, we're nearly there. Who are our clients? Well, they're anybody, aren't they? You, me, family, friends, a work colleague, granny, sister, anybody. Some feedback from one of our clients' mums. Let me just take a minute to read that. And a second one from a carer there. And sometimes that support was on the telephone as well. Sometimes carers live at a distance away and we can be on the phone to them, supporting them. And just in recognition of what we do, and I would say, wouldn't I think we do it really well, we were awarded this 3 years ago. So thank you for listening.
Thank you. Conscious we probably haven't had time for questions, but I know that I think Jenny, Mary and Jane will be staying for the panel now.
Yeah.
And any questions obviously may be relevant to any of the other presentations you've heard we could pick up. Debbie, is it proposed we put a few seats at the front for the panel? It might be easier.
I wonder if those who gave presentations could like to move a little bit more forward. I know Joe and Julie from the other group.
If we could grab some of the seats from the front, and then bring them forward. Right. opportunity to grill our presenters this afternoon. And as I said, you know, at the very beginning, I mean, this really is an opportunity to ask questions, to you know, provide some sort of feedback, which can help inform, you know, where we actually go with, you know, the output to this workshop. So, over to you, please, and there's a whole array of individuals that you can fire your questions.
Shall I go first then? It's quite a small and specific point, which is about the carer's passport for the Royal Surrey. And you were just talking about how helpful that whole car parking would be. I'm sure you've thought about this already, but it just occurred to me, if you had a small, you know, card or stick there for people in receipt of that, do you have any bays that are suitably kind of reserved?
I can't tell you how difficult it was to get the whole free car parking.
Okay.
I mean,
so
car
one step
parking
at a
is,
time.
it's obviously it's income for the trust, so we really had to battle quite hard to get it. We can only give it to certain families. We can only give one per family, which can seem to be really difficult to say. No, we can't give more than one, but we will have it withdrawn from us if it's, you know, yeah. So I'm afraid I know when it. No, it's really good. And as I said, I don't think it's so much about cost for people. People just look so relieved when we say it. I think they just don't have to kind of think about it. So I think we, as I say, it was a battle. But yeah.
And we know that Epsom, St Mary Hospital, are looking to do the same process, so that I think that would be very welcome. Seema's here from Ashford. Sorry, Seema? Are we, the carer's passport also is going to be rolled out at Ashford St Peter's?
It is, it's still in the pipeline, but it's being accepted by the professionals at the moment, but that is something that we're looking to run very soon.
Thank you, Seema.
Hi, sorry. I work for a nursing home. I worked many years in a hospital with acute care. That's why I learned pretty much there how mouse care, turns, washing. And some nurses taught me the value of somebody looking like themselves, especially in the hospital, having their perfume, their hair, etc. But in nursing home I work, it's a very good one, don't take me wrong. These things I kind of learned between us, but there's never been a course, either by the hospital or by the nursing home, to say this is what we should do. There's been queries about mouse care sticks we have. Are they suitable? Are they dangerous? Some people say they might bite. No, these are new ones. So this has been a really good afternoon, and I'm very grateful. But I wonder if in the future it would be a compilation of very practical aspects of end of life, and as well these little things about how people look well, how can we make them look their best, their nicest. This is how
I don't know if Leslie would like to respond to that, in your experience.
Not really.
No, okay. That's all right. I think one of the things I saw at the weekend, and some of you might have seen on social media, there was a lady who had cancer herself, advanced cancer, and she wanted to feel good about herself. She went down to her local beauty salon and was going to receive a manicure. Some people are nodding their heads. It was a big feed over the weekend, and they refused to provide her with a manicure until they said. Actually, that wasn't technically right. They said what they would do is they'd provide her with one if her GP, like Simon, filled in a letter, which I'm sure Simon's probably got a lot more things he could be doing with his time. And I think that whole dignity and respect, and just because someone has an end-of-life diagnosis, doesn't suddenly put them in some other place that they don't want to do those things that actually make us human. Go, Jane.
We work with a charity called Look Good, Feel Better, and they provide a number of workshops in different, usually acute hospitals. Are they in hospitals? Yeah, they run workshops, and that is about making, when you've been diagnosed with cancer, making, it has historically been women, but now includes men, feel better about themselves. So look at their hair, their makeup, including their nails, and they are aware when somebody's been diagnosed with cancer, what they can and can't do to make themselves feel and look better. And we've just started to work with them individually in home for clients. So they're actually going into people's homes when they don't, they're not able any longer to get to the hospital. So have a look at those. Look good, feel better. Google it, and they'll come up.
And we'll share the link.
Yes, it's great.
I think what's really interesting in any of these discussions sometimes is to try and reflect. I think one of the presentations, it's do unto others as you would have done unto yourself, and I think we've all been in those times when we felt pretty poorly, where, my goodness, the benefit in having a wash, a shower, a clean set of pajamas, some nice clean fresh bed linen, you might not be better, but it makes you feel better. And I think it's really important that we do recognise the simple things that do make a difference psychologically to our sort of well-being.
I think that also transfers to the carers. I think if the carers come in and find somebody who's had a wash and they're in clean pyjamas and they've got clean bed clothes, that will make the carers feel a lot better about themselves as well. So I mean, it's a two-way process, isn't it?
And encouraging carers to look after themselves as well.
Well,
I think that's obviously very important as well.
That's our plan.
I wondered if my colleague Jo would just mention about the dragonfly question, which is something else.
I didn't talk about that because this was more about carers. So we've got a sign now, a dragonfly sign that we put on the door when somebody has died and when the person is still in the room. And it's just basically a symbol of people, everyone on the ward and things like that, kind of respecting that the person is in there, maybe the family is still in the time that person is. It used to just be a fairly normal sign that Sarah put on the door saying, do not enter, to no such child. So it's just a respectful sign, and actually it was really interesting. A couple of weeks ago I was on the ward and we had a lady who died very suddenly. The sign was on her door. The phlebotomists weren't aware of the sign, but they actually came up to me and said, oh, what does that mean? And it was absolutely brilliant because potentially they would have gone into that room with their phlebotomists, and it could have been really, really insensitive. So it's just shown it's working, and we've got also some relatives. We've got some property bags as well with the same sign on which are now cloth bags rather than the horrible grey plastic property bags. So when people are leaving the hospital with their loved ones' possessions, they've just got something that feels a bit more dignified to take theirs.
And I think before we can carry on to your question is communication. Absolutely key. I know in primary care for us, we do need to know, please, as soon as possible. Communication is so key because we will send out letters, we will make phone calls, and there is nothing more soul-destroying than to ring a carer or a recently bereaved individual. Communication. So Karen first, please.
I wasn't just going to ask a question, I was just going to comment really. So I'm starting a new role next month, working with the Quality and Care Homes team, and my remit particularly is going to be supporting all of the care homes in Surrey Downs area with end-of-life care. So training will be starting.
So you said about communication. I know of a young carer who is still very, very angry because she wasn't allowed to see her father when he died. What's the age group? Why can't people communicate with that child to say, would you like to see Dad? And she didn't say goodbye, so that's why she's so angry about it. She's only youngster now.
I think that's really important. Jenny mentioned about probably all of us here have probably been a carer. If not, you will be. I lost a very close friend last year with a sudden, very, very quick illness. And actually one of the challenges, which I think brings into that, was actually how to help and support Matty in actually managing his children. It was easy to see the carer, and I think even today you have that sort of feeling it's an adult carer, but actually how do you manage the children of carers? And I think that's a really important aspect here that we need to be quite sighted on as well.
Can I just interject that? You said, how can we manage the children of carers? They're carers too. Remember that, they're carers too.
That's a good point.
Yeah.
Sue, did you want to ask a question? Sorry, I had your hand up, sorry. Apologies.
I was just going to follow on to what you were saying about how to enable far more focus on the emotional side and the little things that mean so much by managing to streamline the bits that you have to fight so hard for, like the steps and the drains and the chair lifts, the stair lifts and things like that. How can that become a little bit more, sorry, I've got a background as an OT, so for me it doesn't seem difficult, but I've had to fight for carers because I know the system and I've got it in place quickly. But it seems that because we're dealing with end of life all the time and this domain, why is that not more enabled to just have a life of its own and to be triggered off and to happen rather than everybody has to fight to make it happen when it is part of the world that we're all trying to support people in. And then it does free people up to spend that very precious time with people and to look after that emotional part of what we're all trying to do as well. And in this day and age, when we've got all these modes of communication and referral, it's still something that we're stumbling over to get that drain. And I just thought someone to get one and learn how to do it. And they went on holiday to Mexico with it. But it was a huge problem. But it's just, how can we all work together? We must have huge amounts of knowledge and brain power to actually make that more fluid as sort of journey.
I think you made the point that we had in our group, which was very much actually this is about integration and actually working together. And I think there is a huge resource. I mean, you know, we've heard from everyone this afternoon what an amazing dedicated resource, and that's in all organisations. And you know, commissioners don't go out of their way to be obstructive. You know, everyone cares. It's a question of trying to get everyone working together, get the best from each other, rather than, you know, I liken it in my world of integration, it's almost past the hot potato, which I think is sort of been a little bit the way healthcare has evolved, and it's time that now we actually come together and work towards one common aim, you know, for the benefit of our patients, carers, and families.
I think there is something about what we commission the carers and people who are dying. Within 2 days of Seth's diagnosis, somebody from Relevant Cancer Care felt like badgering me about personal independence payment and filling in a form, and they were phoning me all the time about it, and it was the last thing on my mind. And I understand that for some people that money would be a lifeline, and you know, I don't want to complain about that, but it really was at the bottom of my list. But for 14 days we waited for the palliative care team to have a conversation. Somebody, knowing that Seth wanted to die at home, could have arranged for a bed to be ordered, could have arranged for some of the things that we needed to facilitate that. But we sat there for 14 days. We didn't know at the time that was half of Seth's life expectancy. Why did we sit there for 14 days? And why weren't we commissioning a rapid response in terms of the palliative care support? So I think, you know, Homeward Bound can bring some of those discussions out about where we do focus the commissioning. And I'm not knocking the personal independence payments and the Relevant Cancer Care, but for me, for commissioners to have commissioned a more rapid response to the diagnosis, given the shortness of prognosis, would have been so much more beneficial.
I would just say, in response to both Rachel and Carol's point, that the NICE guidance around supporting adults in the last year of life, which was due to be consulted on this January and is still in discussion with the various leads, does address both those points, so the timeliness, but also young carers and the need to support them. So I think when it is finally published, I think in terms of supporting commissioning, that will be a very valuable tool. In the meantime, we only have one chance to get it right, and we absolutely need to you know, keep going and achieve that.
conscious of time, so if I could thank our panel, all of whom given their time and their presentation this afternoon. I understand that the presentations will be circulated to everyone. I think what's important is that Mary's actually does include a few slides that we're missing, so we need to get that right. But otherwise, thank you all for attending, and I hope you found it as worthwhile an afternoon as I have.
Before I reveal what history of the cars, I'm a proud new owner of a mobile phone that was left in the other room.
Has it got a password?